We can make a start, and
Yeah.
then whoever else joins can join. Yeah, thanks for coming, everyone, and a massive thank you to Dr. Dimitri Amiras for being our speaker on extended reality and IR today. Just going to go through a few different things that he's been working on and he's trying to develop and practice, and yeah, it should be an interesting talk. So I'll hand over to him.
Thanks very much, David, and thank you everyone for joining me for this talk. I'm going to talk to you about the use of extended reality in interventional radiology. I work at Imperial College Healthcare Trust, and mostly at St Mary's Hospital, which some of you may or may not know. I guess the main claim to fame is somewhere in one of these two windows, I can't remember which one, some fungus came through the window and landed on a petri dish, and then about 10 years later, they came up with the idea of penicillin. So there is some heritage there. So hopefully I can try and inspire you to look at interventional radiology and extended reality. So in terms of disclosures, I'm a paid speaker for Microsoft and Canon, and I'm also a medical advisor for Medical Eyesight, which is a AR medical company. I'm not an interventional radiologist, but I am a musculoskeletal radiologist, so hopefully you won't hold that against me. This is an image that was taken from a book that looked at all the medical things that happened during World War I. And if you remember, the idea of using radiographs was actually just at the turn of the century, and it got really pushed out a lot during World War I. And this is a field medic trying to remove a bullet. And you can see here that he's wearing like a fluorescent screen, and he's able to see the bullet and his device to try and extract the bullet without causing as much damage to the patient. Unfortunately, at that point, we didn't know so much about the dose associated with dose to his eyes he would have and the radiation dose. So these days we have to do things a little bit more complicated. But I'll hopefully show you today what is extended reality, what that means, some idea of clinical uses, how we can use it in training education, and hopefully there's enough time we'll talk to you about regulation. So in terms of this concept of virtual augmented reality and mixed reality, it's a continuum with on one side virtual reality where most things are digitalized, and on the other side you've got the real world and some digital objects in there, which would be what we call mixed reality. And augmented reality and virtual reality have been around for quite a long time. However, recently we've seen there's been a real growth in this, and this technology is now at the position where it's really starting to change the way we do things. A lot of that has got to do with improved technology, and this is an example of using deep learning techniques to map a human body, map not just where its shoulders and elbows are, but even the wrapping of the skin, and exactly in a very precise positioning at high frame rates. We're also able to record things in a different way, not just simple video, but we can do 360-degree videos where we can look around and understand how things look. So this is really important for education and training, and you can understand what an IR room looks like, what's going on during a procedure. Great for trainees, but also really good for patients if they've got anxiety about these things. So in all these kind of technologies have got a blanket term of XR, extended reality. Showing my age here, but this is a clip from Top Gun, and this would kind of be augmented reality. We've got an overlay of digital information to the real world. And virtual reality is where everything is completely digital and nothing is particularly real. So you may hear some of the more senior IR guys say that you don't need any of this technology, but in reality, they're actually using forms of augmented reality before we really knew what it was. So why do we look at these new technologies? So clinical practice is changing. Safety is becoming more and more important. We have a diverse workforce with different levels of experience and expertise. There are increasing costs associated with medical care and increasing complexity. So being able to augment human performance with technologies is going to hopefully solve some of these problems that we're facing. So one of those in particular is something called spatial cognition. It's recognized to be really important in minimally invasive surgery. And some of you may be thinking about doing an interventional radiology and thinking, well, you know what? Sometimes I find this spatial cognition stuff difficult. I can't quite understand 3D shapes. And it's possible that actually using augmented reality will help to supplement that so you can try and achieve those goals that you want. So I was saying before how we were using augmented reality before, we just hadn't called it that. This is a digital subtraction angiogram. And this is actually a form of augmented reality because the mask that is put in place to allow you to guide your wire is created, and it's digitally created, and it's a digital object in the real world. And this is the kind of latest version. So this is an open source piece of software where we try to guide biopsies using a head-mounted display, in this case the Microsoft Hololens, to reduce the amount of radiation dose, procedures you need to do to do a biopsy. This is an example of the future of the IR suites. So this is a little kind of promotional clip from Philips. And this is the way they kind of envision the IR suite to be in the future. Feel free to ask any questions as we go along. Some of you may not think it's that practical for an interventional radiologist to move their hands like this in the middle of a procedure, but I think it's really exciting how these things are changing. This is also from Philips, and this is a bone intervention augmented reality system. And if you think about spinal surgery and spinal intervention, high risk of complication, high levels of wrong site and wrong level surgery, never events, hopefully could all be limited by the use of technology such as this. This is some work we're doing at Imperial, looking at correlation of anatomy, so 2D planar anatomy on angiograms, and then your 3D kind of CT angiogram. This is a really great example of some other work done. And this is a phantom, which some of you may be familiar with, and it's for training and doing CT biopsies. And what they've got over here is a grid, and we use this grid to help tell us where our needle is when we start doing a CT biopsy, because we can see it here on the patient, and we can also see it here on the phantom. What's really clever about this is not only can we see it, but this device is also, this HoloLens here can also see this grid. And this is actually what we call a mixed modality fiducial. And because we can see the grid on the CT scan and the HoloLens can understand what the grid looks like in 3D space, it can also project the anatomy. And here, these are little balls, but in the future, this could be a patient's anatomy. I mean, there's the spine, could be ribs. And the user is able to do a biopsy by just looking at this object, hologram, and putting his needle towards it without having to do repeated CT scans. And if you can see here, these are all the metrics that were measured in this study, and they've got some with augmented reality and some with augmented reality and some without augmented reality. And you can see that there was no non-target selection. There was much less passes used, much lower doses in the two groups, and also reduced procedure time. So if you're a patient, what would you rather have your your IR technician use? The HoloLens or not the HoloLens? This is another example of a mixed modality fiducial. This is for fluoroscopy. It's a really simple kind of image. The HoloLens can see this image, and you can see it on the fluoroscopic image, and you can put those two together and create that kind of mapped image for you to understand when you're wearing the HoloLens. So this is kind of computation that would be happening in your head normally, whereas it's taken over by all these devices. This is some early work we did at St Mary's Hospital, and this was for percutaneous flap fixation in our trauma patients. we get high level trauma patients, and a lot of them have open wounds which need covering, otherwise the bone will get infected, etc. And the key for that is selecting the right perforator. So we do that using CT angiograms, identify the correct perforator, but then communicating that to the surgeon in the operating theatre can be difficult, and they also identify them using small handheld Doppler devices. And that can be quite technically difficult, and they may, miss a good vessel that we've identified on the CT scan. So this one, we mapped the CT scan onto the patient. The user was able to see it on wearing a Hololens, and was then able to mark the skin. And these skin markers tell the difference between what the Doppler showed us, what the Hololens was, and then what it was in real life. Also use extended reality for the patients, so helping with patient education, and also in pain control. So mostly it's used as a distraction device. You can see this is a burns patient who's using VR to distract him, and here's someone having a tattoo done, and it's helpful for distraction there. We're doing a case study looking to see if it's possible to use it for patients who've got claustrophobia in the MRI scanner. Another concept is this idea of telepresence. This is some other work that was done recently during the COVID surge, and they used the Microsoft HoloLens so that you could have one patient in the room with a patient, one doctor in the room with a patient, and then the team remotely looking at the images but having to wear lots of PPE. But if you translate this into the IR room, you could have an IR practitioner doing a procedure. You can have experts who could be thousands of miles away giving advice. You can also use this way to educate people at distance, and I think we're now doing ward rounds across the world doing this. Getting onto this idea of education. Anyone know who this is a bust of and who the quote's from? Silence. No. Okay. Well, not many classical scholars then. So this is Plato. It's a bust of Plato. I don't know anyone who actually knew what he looked like, but this is one of his quotes. So some things you just have to do. We can talk about them, we can describe them, and we can share our knowledge, but sometimes you just have to do it. And I think that extended reality is going to be really great at helping training. And I've got an example of how we've done that. But most importantly, why do we need to do this? So we have a workforce crisis at the moment. We, especially in interventional radiology, this is also a worldwide problem. We can't solve this by continually importing our expertise. It takes a long time to train an interventional radiologist. Also, we've got really high patient expectations. What we were doing is groundbreaking procedures 5 years ago and now expected. Safety is a big issue in healthcare, and we need to improve safety as a group. We could be a lot safer, and we should strive to do that. And technology can help us with this. And the recent challenge of COVID-19, I've showed you one example where it's been useful. And we are now looking to train. We're having to train people remotely. We're having to do things in different ways because of this pandemic. So some of you will be familiar with what's called Halstead's model of teaching. Halstead was a surgeon. He actually was from the US, and he went to Europe to go and look at what the surgeons were doing. And he spent his time in operating theatres across Europe. And he realized how important that training experience was. So when he came back to form Johns Hopkins University Hospital, Dr. Hopkins Hospital, he set up these amphitheatres in the operating theatre. And they're quite good if you're either side of the surgeon, but I know when I was a medical student, there was a whole bunch of us huddled around. You didn't really see what was going on. So this can definitely be improved. In radiology, we do what's called radiology direct observation of procedure skills. So there is a bit more structured learning, a bit more reflective learning. But simulation, I think, has in the last 10 years, we've started experimenting with simulation, and even very simple simulation This is a study where they put like a similar to the CT phantom that you saw, but it's actually just like a box. They put it in the CT scan there, and they allowed trainees to do some CT biopsies with it. And it showed that it reduced procedure time, it reduced radiation dose, it improved confidence in trainees, and they were actually able to transfer this to clinical practice, improving patient care, and yet again underlining that point of safety. So I think it's important that you do get to do things, and you need to do it in a safe environment where you feel comfortable doing it, where you can ask questions, where you don't feel stressed if something goes wrong. So this is like a really simple app that someone's produced for their mobile phone. So it's just to learn kidney ultrasound. It uses the motion sensors in your phone to simulate holding an ultrasound probe, and as you move the phone, it gives you the 2 poles of the kidney. So this is the kidney adrenal gland at the top, and it's trying to get you to make sure you get the longest length. And like a very simple app, it showed that it improved the participants' ability to find the best length in the kidney, and it reduced training time. I've already shown you this video of the IR suite, but you can already get some understanding of what's going on in there, how things are being used, and where to be. Here's some examples of ultrasound training devices. So again, you can start learning this stuff before you actually get into the field and reduce your training time. At Imperial, we've got an immersive technology initiative for this kind of medical education, and we produced an app recently which was based on the Hololens, and we completely simulated a CT biopsy procedure. You put on a HoloLens, and you're able to use a real biopsy needle in a phantom bit of tissue, which is just agar jelly. You can get the tactile feedback from the needle. You can simulate taking a CT scan. You can advance the needle down, and you can learn those 3D spatial skills. And you just have, these are one of those things that you just have to do. And because this is what you would do in real life, exactly the same procedure, you get to learn it quicker. And we got some really good feedback from this. Now, I was hoping to show you our latest iteration of this, which is something you could do without HoloLens and just on your laptop at home, but it's still in production. This is an example of one of the targets that we could get people to do. And you can change the difficulty of the targets. And, you know, although you could go near puncturing a liver here or puncturing the kidney, you never would. This was the feedback that we got. So a lot of people felt it's realistic, and a lot of people, again, felt more confident after doing it. So it looks like I'm going to have a bit of time to talk about regulation. Are there any questions while I just take a pause for a minute? Guess not. So I'll carry on. You know, these devices are coming on quick and fast, and it's important to think about what's the design of these devices, and also how we regulate them in healthcare. So these do, although they're supposed to offload cognitive cost, a lot of you that use computers to do presentations, you'll realize that sometimes using technology actually does take some load on to your brain. And these things have to be designed in a way that it doesn't actually impede your ability to do the tasks you need to do. There's also this like huge attraction with new technologies, and it's really attractive to go and say, oh, you know what, I'm using the HoloLens to do this. But if it's going to make the procedure less safe, or it's untested, should we be doing it? And one method that we can use to kind of assess that is called the ideal framework. And it was an idea put forward by Peter McCulloch, who was saying, when we do devices, we don't actually treat them the same way that we treat drugs, and we should give them the same framework in terms of trials, and make sure that they pass all of those before we put them forward as medical devices. So this will definitely have to be applied.
Sorry, there's just a few questions in the chat from Ahmed.
Sure.
Are there any plans of using haptic feedback, for example, in gloves? so you can have the sensation as well?
Yeah. Yeah, so we've been experimenting with a few gloves. Unfortunately, they're quite bulky, but they are getting better as everything. It's getting a bit better and a bit smaller. And that, yeah, again, that's kind of moving towards the VR side. But yeah, definitely, if you can replicate something accurately, then it's great. One of the principles I try and use is, let's not try and create a solution for a problem we don't have. We're able to do pretty good haptic feedback with a bucket. But if there's something more complicated, can we replicate it with minimal technology? So hopefully it will get there one day.
There's another question about any issues with nausea or dizziness, for example, when using the virtual reality rigs.
Yeah, so I think that's definitely true. And my experience with the Microsoft Hololens, even the latest version, is that you do get a headache. It's not the lightest device on your head. They say it's like wearing a baseball cap. It's probably a little bit heavier than that, and it is a computer, so it heats up. So you can't wear it forever. And the nausea and all of that are important things to look at too.
And there's just another couple. To what extent has this been added to undergrad medical studies, and has RCR mentioned interest?
Yeah, so certainly at Imperial, it's being used for an anatomical teaching. It's also recently been used to take people on ward rounds, because obviously it's more difficult to do ward rounds now because of the coronavirus pandemic. And have the RCR shown interest? There is some interest with the RCR, and people are very supportive about some of the biopsy projects that we're doing.
And the last question in the chat is: the NHS is a little behind. How long do you feel this would take to be implemented, and is it cost effective?
Is it cost effective? Yeah. So, yeah, I mean, we say the NHS is behind technologically, and I think, I think sometimes when we look at in IT as such, we can be a bit behind, and I do think things are changing. I used the example of penicillin earlier, so going to get this right, hopefully. So I think it was 13 years from the discovery of penicillin until it was actually used to save a life, and then a few more years after that before it was actually in mass production. So I think we're much closer than that, because there already are companies that have got CE marked augmented reality devices. There are already companies that have got FDA approval, but and actually in some ways we're already doing this already. There's the example of digital subtraction angiography, but you're going to see stuff in the next, I think, 2 to 5 years that's going to change the way in which we're doing procedures.
That was all the questions. I think we probably just finish up in the next minute or so and see if there's any more.
Yeah. So so this is my summary slide. So I think it's important for economical reasons. It can be scalable. It can be reproducible in terms of training, and I think it will open up access to training, as well as also making a more feasible form of assessment. This is my email address if any of you are interested in getting involved in any projects that we're doing at Imperial. Please feel free to get in touch. And yeah, we'll these next few minutes or next few seconds take any questions if you guys have got any.
Any more questions in the chat? Or anyone want to ask a question directly by sharing their camera?
Feel free.
If not, thank you again, Dr. Amiras. Another really interesting talk.
Pleasure.
Thanks for everyone who asked questions already. It's interesting to hear what kind of other issues people are thinking.
Definitely. Yeah, I think you have to look at lots of everyone's viewpoint is important.
Anyone in Leeds doing any XR radiology work?
So actually, I've already given a talk for the Leeds. There's a Leeds. What is it called? There's a Leeds XR team, and they're in the university, and you should get in touch with them. I'm sure. Oh. Yeah. There you go.
Well, there you have it.
Okay. So is anyone doing XR radiology work? Well, I'm not sure. I don't know. I think, yeah, I'm not sure if there are any radiologists that I'm aware of. But yeah, if you know anyone, I'm happy to point them in the right direction.
Great. We just have one comment in the chat. Can you read that?
Oh yeah, yeah. So Angelica says that she did an intercalated BSc Imperial. First session trialing the HoloLens. Yep. Do you know if there's been any more progress in introducing at the medical school? So I know they've done cross Atlantic ward rounds in terms of medical school education, and there's a lot of work going on in terms of anatomy training, and we're trying to do some work in radiology training, and I think you'll be seeing a lot more of them in medical schools and in the hospital when it comes to sharing information and sharing training opportunities. Who knows, the next conference we do might be in virtual reality.
Yeah.
It's enough technology now.
Great. Does anyone have any more questions? You can just put it in the chat, or you can request to share your video.
Please do.
No. Maybe people just go to bed already. Yes.
Yeah. It's been a long day, I suspect.
Okay. Well, we have a 15-minute break before the next session, and then we have the sign off. But yeah, thanks for everyone for coming to this talk. Thanks for getting involved. Dr. Amiras, thank you again. It's been an incredible talk.
Pleasure.
Great to have you.
Thank you very much. Well, thanks for having me, and enjoy the rest of the day. Okay, bye everyone.
Bye.